The next talk will be by Dr. RITU Arora. The volume is not on this
session, but I am sending you my recorded version. Thanks to Dr. Vanati for making me part of this instruction course and sharing my views on keratoplasty concerns and keratoconus. As you know, now with the advent of cross-linking, keratoplasty in keratoconus has become much lesser, though keratoconus patients are in the excellent prognosis for keratoplasty. I have dealt with this topic, dividing it into different parts as to when to resort to keratoplasty. In case I decide to do keratoplasty, what to do, and which part of the keratoplasty to be taken, and how to go about these different surgical options. And the when part of keratoplasty comes, that when we are dealing with advanced keratoconus, we still have in our country patients presenting to us with markedly advanced conus, especially in children. When the thinnest cornea may be less than 350 microns, we do get patients with thinnest cornea less than 200 microns also presenting to us with markedly diminished vision and keratometry going to 70 and 80. Other indication for doing surgical intervention and cross-linking is not possible for whatever the criteria may be. Or in cases when sometimes the cross-linking has been done and with whatever best options, the best corrected visual acuity is not improving and we are dealing with a young patient in front of us. Another indication at times is when we have a central healed hydrops and there's a conus with advanced scar. It's not uncommon, especially to see patients in my kind of a practice when they present with conus with central thinning area 280 microns, and so there's no other option left except to resort to a surgical intervention. Or when they present to us with healed hydrops with a scar in the central area. So after we have undertaken the thing that we are going to do a surgical intervention, there are different multiple concerns. Though surgically, they are all in the excellent grade for prognosis for management, but the concerns which may come when they have associated, because a number of them have associated vernal keratoconjunctivitis with them. It is this VKC, they may come with advanced papillary reaction, cobblestone papillae, and these need to be managed before any kind of an intervention, even cross-linking or a surgical management is done, because these are the ones which are constituting the environment or the milieu for the eye, for the cornea. So the management of these become very crucial, especially when the patient is to be taken for a surgical intervention. We manage them with giving them high-dose topical steroids, may need immunomodulators, and that is the time when the papillae resolve and they are taken up for the surgical intervention. They may have an associated dry eye because of the conjunctival goblet cells being completely damaged. Because all these will alter the surgical management in keratoconus patient. Because of the associated VKC, they may have peripheral vascularization and even limbal deficiency, which comes in the way of surgical management of these patients. Number of times, the recipients are younger in age, so they may be pediatric age group or they may be in teens, so the surgical management and the concerns are what as we do the pediatric PKs, because they have a hyperactive immune system. In case we decide to do that surgery has to be done, the surgical intervention would be whether we are going to do a peritonic keratoplasty or we are doing a deep anterior lamellar keratoplasty. I have not dealt with other surgical managements like intracorneal rings and Bowman membrane transplantation, because they are also being done in these cases of conus. As far as possible, whenever I have the choice, I like to perform a deep anterior lamellar keratoplasty, and definitely like to attempt a big bubble. And though there are multiple techniques described for formation of big bubble, Dr. Fogla has already talked about whether we are going to be using the cannula over there, or we use IOCT so as to know what the needle placement is. But word of caution, if you have a keratoconus with high drops, avoid forming a big bubble over there. The bubble formation is not difficult because as we go with a 30 gauge needle, the needle track or the view is all along there. And try and get across to the paracentral area with the tip of the needle. That is when you get 100% bubble formation. In case one is not successful in forming a big bubble, go layer by layer so as to preserve the Descemet's membrane. And always have a standby good quality of cornea even you're attempting the DALC so as to avoid in case the perforation takes place. This is my technique of forming a bubble. I go my needle paracentral and then slowly inject with the 30 gauge needle and 2 ml syringe. Forcefully bubble formation takes place, and this is not difficult. And as far as the trephination is concerned, I like to take large grafts. They may range from 8.5 to 9 millimeters. I've even dealt with 9.5 mm post trephinations. Like to do the same post and the donor so as to correct the myopia. And also, I've seen the disease progresses over the period of time. So there may be recurrence of the disease in the donor cornea. So it's like better to take large grafts. Max, if I oversize, is by 0.25 millimeter. If I do penetrating keratoplasty, definitely will do a peripheral iridotomy, especially under the trephined edge, so that it does not become a cosmetic issue later. Pupil is always constricted so that we don't land up with a dilated fixed pupil post-op. Always use an excellent grade donor tissue, and I always use intracted sutures because I'm using a large graft. Do not dilate the pupil in the post-op period so as to avoid Orient-Savalier syndrome. Because we are operating on young recipients, rejections take place, but they can be easily reversed. So always be on the lookout for these findings. And these cases are excellent graft and vision prognosis. They may be associated with large astigmatisms, which need management, especially with the use of contact lenses. Since we are operating on patients who have pre-op BKC, we do see shield ulcers also in these cases, which of course heal with proper management. And also always remember that the limbus in these cases is not healthy, so it may land with persistent epi defects. The other important concern, because of the over the long time, when we follow up these patients over 10 years, 15 years, I've seen if the smaller graft is used, we get recurrence of keratoconus in the grafts. And this is another patient who had recurrence of conus in the graft, was being managed with sterile contact lenses till he landed up with eye drops in the graft. And eye drops in a recurred cone in a graft always starts from the host graft junction when the Descemet membrane clears from the host graft junction, but can be easily managed with intracameral gas or air. And this is the patient which I can show you, and this patient is now following up even 6 years after management of the recurrent conus in a graft area. So always remember, and these cases may be mistaken as cases of graft rejection, though they are just a recurrence of cone in a case of graft. Another surgical issue which comes that they may have associated other ectatic conditions like PMCD or diffuse thinning and ectasia. And these are cases where they don't do well with simple PK. They need to be managed with lamellar, anterior lamellar surgeries, or we may have secondary conus post-lis ectasia. They need large DALC or TILC. So, in nutshell, I would like to concise my thing saying that surgical treatment in keratoplasty in conus should be deferred if possible. Once we decide to do what to do, prefer DALC over PK and always use good grade cornea. Thank you very much.
think that was indeed a comprehensive coverage of all the practice concerns which arise when we are seeing keratoconus, which does form a bulk of our practice when you are cornea-focused practice. And I do thank all my speakers for their fantastic presentations. In the interest of time, I think we will have to hand over the hall. We thank our audience for being patient and listening to us for so long. And if there are any concerns which you would want to discuss with us, we welcome you to address the questions to us.